Thank you for having me today. So it's been a pleasure to be invited to this presentation. And my goal is, by reaching out to this audience, is to create change in how we treat and approach interstitial cystitis, or IC, bladder pain syndrome. They all fall within the same scope. And I think before I start, I'd like to thank you guys for having me and putting this together and providing this platform for myself and other presenters to bring this type of information to the audience. And I would like to thank everyone who's going to do something about this information that I'm going to share and that you're going to learn about in this presentation. So I'm going to go ahead and share my screen if that's okay with you.
Sure, certainly.
Okay, so as Dr. Dayton just introduced me, my name is Dr. Mandy, and I am a doctor in clinical nutrition, a licensed nutritionist and a certified nutrition specialist and a functional nutrition practitioner. And today I'm going to talk about a topic that's very, very near and dear to my heart. And that's personally because I have suffered with bladder pain syndrome myself for over a decade. A little bit about me. I started IC Healer after my 10-year battle with this debilitating bladder condition, which I'll talk about shortly. So again, it's called IC, Interstitial Cystitis, bladder pain syndrome, and sometimes it's called painful bladder syndrome. If you're not familiar with this condition, I'll tell you a bit about that in a bit. But if you can just imagine having the worst urinary tract infection of your life all the time, 24/7, that's pretty much what this feels like when you're afflicted with this. Now, I was diagnosed shortly in 2008 after my daughter was born. And at that time, there wasn't a lot of solutions for me outside of the conventional treatments. And my symptoms continued to deteriorate each year. It actually got to me to a point where I didn't even want to live anymore. And so this is what pushed me to seek on what my root cause was and how this started for me. And I also educated myself on just the functionality of the human body. And I then pursued a doctorate in clinical nutrition, and that kind of how I tied all the pieces together. So before I dive into this topic on the bladder pain, obviously we're all here because we share something in common, and we're noticing that something pretty terrible is happening to our healthcare system, and it's pretty much failing, and it's falling to pieces right before us. And, you know, we have to ask ourselves for a second, what's really going on here, and what's wrong with our views of health and disease and how we care for people who need our help. And so how can we should ask ourselves, how can we bring the best of the science and art of medicine to our communities for the greater good? And over the last century, as we've seen a dramatic rise in a lot of degenerative diseases, despite our best intentions to reduce the risk factors. For example, just in the case of cardiovascular disease, right? One of the number one biggest killers, some of their primary risk factors are hypertension, high cholesterol, and smoking, for example. And even though those have been greatly reduced, the fourth, diabetes, has increased. So there's definitely something wrong here. And the pharmaceutical and surgical interventions that are evolving to address the secondary prevention and symptom management doesn't seem to be doing the trick, so to speak. So, as we can see, chronic disease is now the principal cause of disability and use of our health services, and consumes about 78% of our health expenditures. And so we know that there are many factors that can contribute to chronic disease. And as we know, it's a tremendous burden on our national economy. And so we are constantly trying to, look up ways, to address some of the root causes. So some of these are listed here. For example, we know there's genetic vulnerability. So you're kind of born with the genetic predisposition. But then there's things that we can control, like environmental toxicity or poor food quality. Or even sedentary lifestyle, not enough exercise, chronic stress, and fragmented families, indoor living, and obviously an aging population. So these are some of our, in this little chart, you can see some of the different factors that play a role in this. And of course, as we've seen over the last 50 years, we do have this quick fix mentality. And this is something that I still struggle with, even with my own patients. You want that quick fix. And it really creates an unhealthy cycle that drives, drug dependency. And it does often ignore healthy behaviors. And as a result of this, what ends up happening is there's less time spent with patients, and the care isn't patient-centered like it should be, and it does fail to account for individual biochemistry, bioindividuality of each person. And so that kind of brings me to this concept of integrative medicine, which I love so much, and I feel like it is the future. And it is patient-centered, and it reaffirms the importance of the relationship between the practitioner and patient, which I think sometimes we forget, in a busy practice, and, you get lots of patients, and it does cause this relationship to be broken. So in the integrative model, and I believe is the model of the future, it does focus on the whole person. Obviously, it's evidence-based. It makes use of all therapeutic approaches, and everyone's involved. No one's excluded. So all healthcare professionals are involved in the picture with the patient to achieve optimal health. So the doctor of the future that I envision is going to be an integrative healer whose practices differ in many ways of what we're seeing today. And it's high tech and high touch, but focuses on preventing disease and injury and puts the patient in the driver's seat. And that's really what I'm finding is really helpful in getting patients where we want them to be. Is you put them in the driver's seat, you let them know, we're guiding you. You're not necessarily telling you what to do, and let them be the decision maker. So that brings me to personalized nutrition. So this is my scope of practice, and absolutely love the motto that American Nutrition Association says when it regards to personalized nutrition. It is tailored for you based on your health history, your goals, your tests, your genetics. It's based on your unique biology and your personal biochemistry, and it takes the guesswork out of healthy eating. And that's the motto of the American Nutrition Association. So as you can see here, this is where my CNS credential falls under. And they envision a society of healthy people powered by nutrition. And these are their different fundamental values here. So, what I really love about it is that it is for everybody. Nutrition is for everybody, and every person deserves access to healthy food and unbiased science-based nutrition knowledge. And finally, I absolutely find this to be the future as well. This nutrigenomics is just expanding so quickly, and we're really able to access such amazing information that we weren't able to 50 years ago. And it really does get rid of this one-size-fits-all approach that we've been used to when it comes to food and nutrition. And it starts to talk more about diet, gene, metabolic pathways, and matches the person with the best diet for them. And with the information that we can access now, we can actually create and tailor specific lifestyle approaches that are dependent on each person's unique genetic variations. And it's very, very exciting. And the future, I feel, is very exciting for this field with all this wonderful information we have under our fingertips. So let's talk about why you're here today. We're going to talk about IC and bladder pain syndrome. And so what do we know about this condition right now? So it's still considered idiopathic, even though I do believe that there is a lot more information that's pointing to different potential causes, such as infection and those types of things. But in the literature, it's still considered an idiopathic disease. And IC-BPS is an umbrella term that's used to define many symptoms, very similar to IBS. And historically, it's been considered non-infective, although now with some of the newer urine testing, such as the PCR and the whole genome sequencing, they can actually point to bacteria as being an underlying factor, although not one bacteria has been actually identified. So that's, a little bit on the newer end of how this disease has been treated. And then there's two different kinds of IC. There's ulcerative, and then there's the non-ulcerative subtype. So generally about 90% of the patients have the non-ulcerative type, and then about 5 to 10% have the ulcerative type. And right now, from the latest numbers I looked at, there's about 2 to 8 million women and 1 to 4 million men in the United States that suffer from this condition. But that number is actually rising. So what are the symptoms? Well, I can tell you what they are because I've had them. It's horrible. It's constant burning, pressure in the pelvic area, urgency, frequency, constant trips to the bathroom, middle of the night, all day long. Some people will have urinary retention. Others won't. Others have the frequency. There's a lot of pelvic pain, painful urination, painful intercourse, and then there's the nighttime urination. So those are the most common, although there's other symptoms as well. Many of the patients also have digestive issues, IBS type symptoms, other autoimmune conditions. So there's other conditions that they may be afflicted as well as the bladder, but these are the main symptoms of this. And the conventional treatments, some of them have been used less. For example, Elmeron, which was used for many years, is not being prescribed as much. I think they had a problem with a few lawsuits with some issues that afflicting the eyes. But amitriptyline is often used. Different antidepressants are used. Bladder installations are very common. Hydrodistension is still used. Pelvic floor therapy. Antihistamines are often prescribed. Immune suppressants. Surgery, I don't think it's happening as much as it used to maybe 20 years ago. And then now lately, antibiotics have been commonly prescribed now for IC. And so some of the causes of IC that might not be as commonly known, so I mentioned earlier, the infection piece of it is something that's relatively new. Histamine intolerance and mast cell activation, autonomic dysfunction, autoimmunity, pelvic floor dysfunction, hormone imbalance, especially after menopause. Now, this is one that I'm going to be spending a little bit more time on: hyperoxaluria and oxalate toxicity. And then there's the hypercoagulation, and then genetic predispositions. So I'm going to focus a little bit more on the hyperoxaluria and dive in a tiny bit on the genetic predisposition. So some of this might be new to the listeners today, and maybe for some of you it's not, but it is very relevant to the symptomology and to just the pathology of this condition. So oxalates you might know about in plant foods. So when you think about oxalates, you might be thinking of kidney stones, for example. So oxalic acid is obviously in plants, and they're there to, as you know, to deter insects from eating them, but they're also there for structure, and they're naturally occurring. We are designed to break them down. I mean, we have microbes that are designed to break down oxalates in our digestive system, but unfortunately, obviously, with gut dysfunction and dysbiosis and some of the exposure to antibiotics, it does cause problems from that perspective. But truthfully, oxalates are considered anti-nutrients. They do bind minerals just by their nature because they're negatively charged. And as a result of that, too much of them can actually prevent absorption of minerals. So they're known as mineral chelators, and they have a very strong affinity for positively charged minerals. And that includes magnesium, calcium, zinc, and iron, for example, because oxalates are negatively charged. They do also bind to heavy metals as well, and as a result can cause a lot of harm in the body. As you can see in this picture here, they're actually very sharp. I remember the nights and days of passing these through my urinary tract. I can literally feel them passing through, felt like glass. But this can actually happen in any part of the body, not just the bladder or the kidneys. So the oxalates can actually be a problem in many different conditions. And here's a list of some of the things that they can actually do. So we traditionally know oxalates as being associated with kidney stones, right? Calcium oxalate stones. But there's other kinds of oxalate stones. It's not just calcium oxalate, but that's the one we know mostly about. And here's a list of other conditions a lot of people don't realize, even breast cancer. When there's biopsies done of breast cancer tissue, sometimes they will see the crystals in there. Pulmonary fibrosis, fibromyalgia, endometriosis, and then obviously interstitial cystitis, as well as, I forgot to mention, vulvodynia is also a very strongly associated condition with patients who've got interstitial cystitis among the female population. I had that as well. Osteoporosis, diverticulosis. So you can see there's a wide range of different conditions that can be associated with excess oxalates. Now, the one thing is, I think we mistakenly think that the oxalates are coming primarily from our diet. And I'm here to say it's not really the case. Maybe about 30 to 40%, unless somebody is a vegan and that's all they're doing is juicing spinach and celery all day long, then perhaps for that person, the diet could be the biggest contributor of this. But about 30 to 40% of it is coming from the diet. Like I said, we are equipped with the ability to break them down in the GI tract. We have microbes for that very reason. What a lot of people are not realizing is there's actually other contributions to oxalates, and that includes microbes such as mold, actually, and yeast in the GI tract. And that can be both directly and indirectly. And then finally, oxalates are actually part of our endogenous metabolism. We can actually make oxalates within your own metabolism. So that what I think is really, these last two factors are really the biggest contributor that I'm seeing amongst my patients. Now, the other thing I should mention is there are genetics that are associated with it. Now, truthfully, only about 10% of most people who have hyperoxaluria are going to have a genetic predisposition or component to it. But my patients, because I've been actually tracking this and I've been documenting this, I have 40%. So within my patient population, 40% of them have one form of these genetic polymorphisms, though generally speaking, it's about 10% amongst the general population. So that kind of makes sense. So it seems that within the IC population, the oxalate genetics are a bit higher in prevalence. So some of these, I can just explain briefly what they are. So this first one, GRHPR, that's glyoxylate hydroxypyruvate reductase. And this enzyme converts glyoxylate into glycolate, which normally can be eliminated from the body. But when there are polymorphisms, then this conversion doesn't happen. And then we end up forming oxalic acid, and then they precipitate. SPP1, which is the polymorphism that I have, that is a protein encoded by this enzyme that's involved in the attachment of osteoclasts to the mineralized bone matrix. And this can just inhibit calcium oxalate crystal formation. Osteoponin is a critical inhibitor of calcium oxalate crystal formation. And so what this particular thing does is it does upregulate a cytokine. And as a result of this mechanism, it increases the likelihood of calcium oxalates accumulating in the urinary tract. Then there's this one here. It's called HOGA1, HOGA1, and it encodes a mitochondrial 4-hydroxyl 2-oxoglutaric aldolase. And this is also involved in the pathway of hydroxyproline, and that releases glyoxylate and pyruvate. But unfortunately, when there's variations, then there's the formation of oxalate. And then finally, the last one, which is the one I see most commonly in my clinic, AGXT, that's called alanine glyoxylate aminotransferase. And this is a B6 dependent enzyme. And this is really important because when there's a B6 deficiency, it shunts the formation of glycine to oxalates, so that instead of getting glycine, you actually end up with oxalates. And that's often done in the context of vitamin B6 deficiency. And that particular enzyme is most commonly seen with the kidney stone former. So if someone has a polymorphism of this and they have 2 copies of it, they're more likely to have the kidney stone presentation. So, and the B6 deficiency is interesting too, because I have seen so many of my patients have a marginal deficiency or even a severe deficiency in vitamin B6. And oftentimes, you know, that could be due to drug nutrient depletions. For example, a lot of antidepressants, even birth control pills can actually cause pretty significant B6 deficiency. And I do have a lot of patients who've been on long-term birth control pills. So, all right, so moving on to another very, very interesting concept with hyperoxaluria called enteric hyperoxaluria. So this is the type of oxalates that arise from dietary endogenous sources from fat malabsorption. So a small fraction of ingested oxalates are absorbed under normal circumstances. Everybody absorbs about 5 to 10%. However, there can be an increase in GI absorption or hepatic production, and this can then increase the risk of kidney stone or other kinds of outcomes. And this is often due to the increased bioavailability of oxalates or due to GI oxalate permeability. So what happens is when there is a malabsorption of fat, basically, whether it's from poor secretion of enzymes, for example, or perhaps bile insufficiency, poor emulsification of fats. It could be due to gallbladder issues. They may have gallbladder stones, or maybe they have got their gallbladder removed. Then we end up having these soaps that are formed inside the digestive system, and they do tie up a lot of the essential minerals that normally would bind up the oxalates to help excrete them out of the body. And so what ends up happening, because they're binding up all the minerals, we have this passive absorption of oxalates through the GI tract. So in essence, what ends up happening is our dietary calcium, for example, is tied up, and our oxalates can now go through and enter into the digestive system. And this is actually very common. It's a very common phenomenon. You see a lot of patients who've got fat malabsorption, they've got fatty stools, and this phenomenon can actually be happening to them. The other piece of this is as well, a lot of these patients also have dysbiosis. And as a result of that, they may be lacking some of the important microbes. The big one that everyone knows about in the oxalate community is oxalobacter, but there's other strains of bifidobacteria and also lactobacillus and even strains of E. coli that are often utilized to break down oxalates in the GI tract. And so when there's dysbiosis, there may not be the right proportion of the bacteria to help break it down. So this enteric hyperoxaluria is often seen when there's fat malabsorption, like I said earlier. So you might see this in Crohn's disease or cystic fibrosis or pancreatic diseases or short bowel syndrome. But really, it's not excluded to just these conditions. Anybody could have fat malabsorption. If they're, even if someone's following a very, very high fat diet, some of these ketogenic people, 100 grams, 120 grams of fat, it just might be too much fat, and they're not producing enough of the enzymes to break them down, and then this ends up happening. And also keep in mind, a lot of the people who follow ketogenic diets may also be eating a lot of oxalates in their diet as well, with nuts and things like that. And then so that piece I mentioned earlier is also very interesting and not often talked about. It's the mold connection. So this is the concept that colonized mold creates high oxalates. And so as you can see in this study, the calcium oxalate crystals were found in the cavity wall, and this was associated with pulmonary oxalosis. So in this particular study, Aspergillus niger was the main cause of the patient's fatal respiratory failure. So as you can see, because of something studies like this is more than just kidney stones. And I'm not trying to minimize the effect of the kidney stones with oxalic acid, but as you can see, oxalates can be very fatal, and it's worth being aware of this. So this is just a snapshot of the organic acid test that can show if there's mold colonized in the body. And Aspergillus is the most common in documentation associated with oxalates, but penicillium also can produce oxalic acid. And just understand this is a byproduct of their fermentation. And what ends up happening is the oxalic acid combines with calcium oxalates to form insoluble needles, and it's almost like glass, and they precipitate, and they can be deposited anywhere at any local site. So if there's colonization, more than likely there's hyperoxaluria. And this can happen in any mucosal surface, whether it's the nasal cavity, the GI tract, the bladder, anywhere. And really another, it's bad enough that they're sharp and they can deposit in tissues and actually physically hurt, but they also can trigger the NLRP3 inflammasome. So when that's activated, now we have another problem, which is the cell danger response. And so our body's not able to complete all three stages of the cell danger response, and they get stuck. And I see this a lot, where they're just stuck in this inflammatory process. And truthfully, as long as the oxalates are there in their presence, we're going to get this continuous triggering or activation of the NLRP3 inflammasome. And it's really hard for a lot of patients to pull out of this very chronically inflamed state until we actually resolve the oxalate problem itself. And another area that we're finding that oxalates can really impair is our sulfation system. Sulfate and oxalate are bidirectional. So they're exchanged one-to-one across the membrane. And so anytime we have oxalates, we're going to have a problem with sulfation. Now, this is a problem because sulfation is obviously important for detoxification. So as you can see, these two mycotoxins here rely on sulfation. So if we have a burden of oxalates, it's going to burden our sulfation system. And it's just like this vicious cycle. You know, you've got molds, you've got mycotoxins, now you've got oxalates, now you've got a strain on your sulfation system, and now you're having a difficult time removing the mycotoxins out of the body. But it's not just exclusive to mycotoxins. Other things need to be sulfated, right? Acetaminophen, endogenous phenols, catecholamines, and then our hormones, androgens, estrogens, thyroid hormones, bile acids. Hormones, you know, a lot of times I'll see patients who are really, really low in estrogen and sex hormones. And you'll find that their DHEA, for example, sulfated DHEA is very low. So you can see how widespread and how much damage that having excessive oxalates in the body can have, even just beyond pain. You know, truthfully, I tell people they're a poison. They can alter your redox homeostasis. They can hijack the sulfation system, like I just said. They can affect your oxidation rate. They can deplete your intracellular antioxidants, such as glutathione and superoxide dismutase. They're depleting of nutrients. I just mentioned they're chelators of these positively charged minerals. And because they upregulate inflammation, they can also deplete a lot of vitamins that are involved in inflammatory pathways, like vitamin B6. They can wreck your immune system and, of course, activate the inflammasome, which I said earlier. So they are pretty damaging, and it's important to be aware of that. They can actually mechanically shred surrounding tissue, and they can cause cellular damage, necrotic cell death, rupture of cell membranes, lysosomal rupture, and cell and nuclear shrinkage, and they can actually destroy certain organelles in the cells. So now there is some very interesting information about oxalates and chronic UTIs. So a lot of patients with interstitial cystitis also present with chronic UTIs. That was me. I had them as well. And so there seems to be an association with the role of calcium oxalate crystals and deposits in UTI pathogenesis. Although it's not well established. This connection has not been well established. So I really had to dig in to find some of these studies. But this study here discusses this particular association. And the results of the study basically showed that the bacteria from the family was this calcium oxalate deposits were associated with this particular family of bacteria. And when they were sequenced, the kidney stones were sequenced, they found that there was actually bacteria colonized within the kidney stone. And oftentimes they saw things like E. coli aggregated around the calcium oxalate crystals. And they actually inoculated mice with glyoxylate and E. coli. And they found that when they were there together, there was actually a higher bacterial burden when they were together. So there's some interesting relationship between the presence of oxalates and the presence of bacteria. It's almost as if the bacteria like to aggregate where there's calcium oxalates. And I'm not 100% sure exactly why that is. I don't think we really know what it is. That's, you know, why they have this affinity, but it's just very interesting that when they do these biopsies of these stones and they actually can see the bacteria that are present. And it, you know, I think theoretically we can say that dysbiosis can create a urinary environment that's conducive to kidney stone formation, but also that the calcium oxalate crystal deposits can form a perfect environment for the bacteria to then create a UTI risk. And this image kind of shows how this actually happens. Interestingly enough, it says the bacterial enzymes split citrate, resulting in increased calcium oxalate supersaturation. And after that occurs, there's a biofilm. And the biofilm is really what we're seeing when we have patients come in with some of these PCR tests and these genome urine testing. And this is where I've said some of the new information with some of the newer IC practitioners, and they're treating them with antibiotics because of this biofilm formation. But if we go upstream, and if the problem is oxalates, can we resolve the biofilm? That's the question that's always asked. And I believe that's true. We can do that, although it's complicated. You may have heard the name Susan Owens. She is the researcher and founder of the Trying Low Oxalate group. She's been managing that group for probably almost 25 years. So she is really the top researcher in oxalates. And she actually wrote a very interesting blog about Hormones Matter about bacteria and oxalates. And she said that this phenomenon with how oxalate and UTI are associated is similar to how ants or flies may show up in numbers when you uncover food at a picnic. And flagging the increased count of these species on a lab test might have persuaded doctors to treat with antibiotics because there was no other game plan. So I think the question we have to ask ourselves is, treating with antibiotics, is that really solving the problem, or is that creating more problems? And would reducing oxalate have helped solve the problem without antibiotics? And it's an interesting observation, but a very difficult one, because patients are in pain. They're in pain, and they don't want to wait, the amount of time it's going to take to, resolve the dysbiosis and reduce the oxalates, because that could take a long time, and they're in pain and they want immediate pain relief. And that's where, some of these interventions with antibiotics can help. But unfortunately, there's also the downside of that as well. So it's a very complicated thing that, that clinicians are faced with. So I want to dive into a little bit on the genetics of UTI and talk a bit about the NRF2 pathway. This came across my my desk probably about 6 months ago. There's actually a practitioner. You may have heard her name. Her name is Ruth Chris. She's been treating patients with interstitial cystitis for 20 years. She's now retired, and she trains practitioners. So there was an interesting study at the researchers at Baylor College of Medicine and Washington University School of Medicine. And they were basically trying to understand what was the difference between when somebody has a urinary tract infection, why people can recover very quickly and why others don't. And so they identified that during UTI, there actually is a delicate balance between the response that the body has to eliminate the bacteria, and there's a balance between that and minimizing the tissue damage that occurs during the process. And what they found was that the NRF2 pathway stood out as the key contributor to this balance by regulating the potential damage to tissues, as well as eliminating the bacteria. And this is really exciting for a nutritionist, and I'll tell you why in just a minute. So basically, when they treated an animal model of UTI with the FDA-approved anti-inflammatory drug, dimethyl fumarate, which is a known NRF2 activator, they saw that it reduced tissue damage, bacterial burden, and opened the possibility that this drug can be used to manage the condition in the future. And this particular study was in the journal Cell Reports. So this is a little snapshot of that study. So what they said was that 85% of UTI are caused by uropathogenic E. coli. And what happens is these bacteria attach to the surface of the epithelial cells lining inside of the bladder, so the urothelial cells. And when they enter, obviously they reproduce. And while this was happening, they were able to see how the cells fight back at this invasion and proliferation while preserving their integrity, which is important for the bladder to function. And what they found was there's an accumulation of reactive oxygen species, and this would activate an anti-reactive oxygen species response in the cells, and that's the NRF2 pathway. And because of this pathway, it would allow the damage that would otherwise be caused by these free radicals to be minimized. So the NRF2 pathway is located in the cytoplasm, and it's bound to another protein called KEAP1, KEAP1. So it's right here. And what happens is when the reactive oxygen species reaches a certain level, NRF2 separates from KEAP1. So they're bound together, and it's almost as though I tell my patients, it's kind of like a parent, and it's basically dictating what NRF2 pathway can do. And it lets go and lets it go out and activates a series of genes. And what happens is these genes that are activated then produce proteins that block the free radicals, and that limits the inflammation. So that's what normally happens with a normal person. So the genes that the NRF2 activate One of them is called RAB27B, and that is what's involved to eliminate the bacteria. So you have a combination of minimizing inflammation, but then you also have the promotion of the elimination of the bacteria. And this is a very, very highly coordinated event that occurs. And that's how it prevents the integrity of the cells of the bladder. So to summarize the study, the urothelial cells produce reactive oxygen species upon invasion of, for example, bacteria. In this case, we're talking about E. coli. The infection results in dissociation of the NRF2-KEAP1 complex and NRF2 nuclear translocation. And then the NRF2 transcriptionally activates RAB27B and facilitates the expulsion of the bacteria. And then in this case, they use dimethyl fumarate, which is an NRF2 activator, and that promotes the clearance of the bacteria and dampens the inflammation. So that's what the results of the study were. Now, the reason I found this very interesting was because I've been basically documenting my patients, and I actually do check for the NRF2 pathway in the KEAP1. It is part of one of the software that I use. And when this stumbled upon me, I was very surprised, but not surprised, because it all made sense now. 93% of my patients have a polymorphism in the NRF2 pathway, and 67% of them have an upregulation of KEAP1. So KEAP1 being attached to the NRF2, if it's upregulated, it's basically going to dampen NRF2's ability to do its job. It's an upregulation. Now, most of them have one copy, but I do have a few unfortunate patients that have two copies, and those tend to be the ones that have the majority of the health problems. So they have other issues besides bladder pain. They have lots of autoimmune issues and other inflammatory disorders. So to me, this was a very important finding, because it now tied the pieces as to why some people have these biofilm infections that they have a very hard time eliminating, and why others can bounce right back after a UTI. I myself have an upregulation of KEAP1. I have an upregulation, and I also have NRF2 polymorphism. So it really made a lot of sense when I stumbled upon this. As you probably know, because NRF2 is like the superstar these days. NRF2 has a lot of other mechanisms in the body. It does positively affect mitochondrial function and metabolism. It's involved in suppressing oxidative stress and inflammation. And as we know, those two things are some of the most common causes of many human pathologies, including cardiovascular disease and neurodegenerative diseases, as well as cancer. Now, it also can, because it has the ability to suppress oxidative stress and inflammation, it makes NRF2 signaling a very powerful, efficient protector. So we want to really take good care of our NRF2. It also can upregulate genes that are encoded by NRF2. So there's actually target genes that NRF2 encodes, and NRF2 can also suppress genes encoding pro-inflammatory cytokines. So it's got dual benefit. For example, the anti-inflammatory activities of NRF2 include transcriptional upregulation of enzymes encoded by NRF2 target genes. And then these include like leukotriene B4 dehydrogenase, but this helps suppress cytokines such as IL-6 and IL-1 beta. So why do I think this is exciting for the nutrition field? Well, we just learned about a drug that can induce NRF2, but there's actually food that does this. And one of them is, well, as you can see in the image, broccoli sprouts are an example, but this is sulforaphane. So there's a compound called sulforaphane, and it is formed from stable water-soluble glucophoraphin in your cruciferous vegetables. It's no wonder, grandma said, eat your broccoli. This is why. Well, maybe grandma didn't know that, but, they had a point when they said that. But it has to be activated by myrosinase. So broccoli, especially young sprouts, are a very, very rich source of sulforaphane. In fact, 3-day-old broccoli sprouts contain 10 to 100 times higher levels of glucophoraphin than mature broccoli. So you have to eat a lot of broccoli to get the same amount of sulforaphane in broccoli sprouts. I think I read somewhere you have to eat 10 cups of broccoli. So that might be a little too much. So it might be better to go with the sprouts. So it's really interesting because The transcription factor of NRF2 is a master regulator of cell survival to endogenous stressors, and exposing your nutrition to, just a cup or half a cup of broccoli sprouts a day can really, really do some wonders in health. And that's because of this sulforaphane compound. So there are some supplements out there that do have sulforaphane, but you have to be very careful about that. That's the tricky part, is I think a lot of supplement manufacturers, they went crazy with the broccoli sprouts, and you really want the whole broccoli sprout. So if you want to get a good supplement, you want to make sure it's the whole broccoli sprout, because you want to make sure it's enzyme active. I think there's some companies that try to stabilize the sulforaphane. I can't vouch for them. I don't know if they're as effective as the whole sprout. So really, food comes first, right? So if we want to really go in the hierarchy of effective, I would start with whole foods first. And if you're going to do supplements, then really think about something that has the whole broccoli sprout. Usually they're dehydrated as a powder. So there's a lot of studies on sulforaphane. It's amazing what's out there. You just type it in a search engine and boom, all these things come up. There's quite a bit. So what I found was the feeding studies with these cruciferous vegetables that are rich in isothiocyanates has demonstrated that when you consume these foods, there is an increased circulation of NRF2 gene products. So that would be things like glutathione S-transferase and NQO1. So their enzyme activities increase when there is NRF2 pathway induced. Now, isothiocyanates are naturally occurring small molecules that are formed from glucosinolates, precursors of cruciferous veggies, and they're naturally, obviously, in our cruciferous veggies, but they can also be synthetically made as well. And they're very anti-carcinogenic in their activity, because they do reduce the activation of carcinogens and increase the body's ability to detoxify. There's a lot of studies. I don't want to get into too much into that, but there was one in 2009 actually in China, and they had 50 healthy subjects that were recruited to take 2 broccoli sprout derived beverages, and one had glucophoraphin and the other one had sulforaphane, and they compared them, and they found out that the broccoli sprout beverage was able to modulate the disposition of environmental carcinogens and toxins. And this was primarily because of the role of the NRF2 that was in the sulforaphane. So that's just one gene, and I'm not going to spend too much time on this. This is just another snapshot, because like I said, I've been documenting all the different pathways with the interstitial cystitis patients. And I just found it was interesting to see how there's so many different opportunities for problems in the human body. And you can see genetically, how this can happen. For example, I was really surprised to see that 33% of my patients have at least one copy of the hematochromatosis gene for iron storage. I wasn't expecting that when I started documenting everything. So that was a bit surprising. And we know that if there's iron overload or there's too much iron in the body that's not being utilized appropriately, then we can upregulate the Fenton reaction. And we've got problems, with, oxidative stress from that perspective. And then there's 43% of them have an upregulation in inducible nitric oxide and a downregulation of endothelial nitric oxide. So there's a disruption in their nitric oxide pathway. And then, of course, I just told you that 40% have the hyperoxaluria genetics. 90% have some sort of disruption in their PON1, which is used to detoxify glyphosate. And it's interesting because Stephanie Seneff, who's talks a lot about glyphosate, I actually had a conversation with her, and she had mentioned to me that there's actually an oxalate component with glyphosate as well. So that's another one. I do run urine testing of my patients, and I do see elevated glyphosate levels in many of them. We have polymorphisms in ABP1, hemoxygenase 1, and hemoxygenase 2. And finally, the last component was from Ruth Chris, and she had mentioned that 80% of her patients had one form of hypercoagulation, whether genetically or just in their blood. So she has her own panel. So this is Ruth Chris's panel through LabCorp. And her theory was that as a result of infections, there's also an increase in fibrin in the body. And that's a direct response of infection and inflammation. And what it does, it upregulates the coagulation pathway, which can obviously lead to clotting and atherosclerotic plaque, but also biofilms that antibiotics cannot penetrate. And she said about 70% of them had one form of another of either genetic based, or they may have had, upregulation of LDL or other lipids in the body as well. So there really isn't a whole lot somebody can do for this. Obviously, I think the best thing anyone can do if they find out that they have some kind of genetic predisposition to clotting, I mean, the gold standard is to get the inflammation in the body down. I mean, that's pretty much gold standard for everything, is to get down that inflammation. And finally, oxalates can, obviously, I said earlier, they can cause a lot of damage, but they can also cause intestinal permeability. And, I don't need to spend time on that. I think most of you here understand the whole leaky gut connection to health. But really, fixing the gut should be priority with everybody, because the gut and the bladder are tightly connected. They're very associated with one another. They're next to each other. They're not far away from each other, geographically. But clearly, if there's inflammation in one part of the body, there's going to be other parts of the body will also be inflamed, and that does not exclude the bladder at all. So I'm going to skip through this because I wanted to dive into healing. So healing is a multi-pronged approach. I truly believe that there's not, one way to heal your body from something that's chronic. I think it should involve a little bit of everything. And that's why I created this Venn diagram, because I feel like, diet and exercise alone obviously doesn't cut it. There has to be some, stress management. I think detoxification and even some intermittent fasting is very beneficial. Addressing the gut is extremely important. And then there's other interventions as well: chiropractic, osteopathy, physical therapy, PEMF, sauna, and ozone. So ozone is the one I wanted to dive into before we end today, because I think this is of interest to many of you. And let me just scroll through here real quick. You may have heard of Bruce Lipton, really fabulous book here, The Biology of Belief. And it was really eye-opening when I read this, because one thing I really loved about what he said was every cell in the body is intelligent. And every cell knows exactly what it needs to do to make itself healthy and functional. And they can do their best, but unfortunately, they do sometimes come up short. And they need energy to do their job. I mean, energy is everything. I think at the end of the day, if we can just help our patients increase how their body produces energy, I think we can solve a lot of problems. But sometimes the body has to be taught how to do that. The cells have to be taught. And so this is why we have some of these tools that we do. So obviously nutrition is very powerful for improving energy pathways, right? Mitochondrial pathways, citric acid cycle, electron transport chain, all those. Obviously, nutrition is very, very important. Exercise is very important. But there's other tools that we should be educating our patients on, because supporting the body's own natural capacity for healing is paramount to achieving optimal health. That's really what I'm driving at. And so that's where I found ozone. Ozone saved my life. I have to be honest with you. If it wasn't for ozone, I don't think I would have been able to get where I am today with my health. Now, those of you here probably know what ozone is. You probably work with ozone, but in case you don't, it is basically a gas composed of 3 oxygen atoms. And it's different from oxygen, obviously, because ozone is very unstable, and that extra oxygen atom wants to break off and combine with other molecules. But the primary action of ozone is really many things. It increases oxygen efficiency, it modulates the immune system, it can mediate oxidative stress, and it can improve microcirculation. But the last piece is actually upregulates NRF2 pathway. So here we are back to the NRF2 pathway. Ozone's really good. It can be treated locally, systemically. Again, it stimulates your body's own ability to heal, and it helps the body rebalance, but it does not cure. So one thing I have to always tell my patients, ozone is not going to cure anything. It's just going to help your body cure itself. That's what it does. But it's very effective at doing that. So I got into this for my own bladder health when I was suffering with the chronic UTIs, and I stumbled upon this study here, and I thought this was very exciting. This was a 44-year-old woman who had 6 months of recurrent bacterial urinary tract infections. And I'm not going to talk too much about the study except for that fact that she did use ozone and was able to cure her, get cured from the bladder infection with combination of ozone. And I think they were doing some other cocktail installations as well together with it. So that, and it was actually, for this study, it wasn't gas, it was actually distilled water, ozonated water, which is actually what I used when I first started to treat the UTI. And it went on for 15 weeks, and it completely resolved the painful urination, and she had long-term symptom resolution. So that was how I started to educate myself on ozone therapy, and learned a lot of things about it. It's bactericidal, it's anti-inflammatory, and it's analgesic, and it can normalize the antioxidant system. Now, it does address certain bacterial, acute bacterial infections, although I don't believe it's actually killing bacteria. I think that we're now learning that it's not doing that. It's more of a support of the immune system so the body can resolve the infection. So it's not necessarily going and killing bacteria from what we understand about ozone now. But these bacteria that are listed here are some of the most common ones that are seen in a lot of the UTIs with patients with IC, especially the Enterococcus faecalis, Citrobacter, Klebsiella, and even the group B strep. So this was really critical for me when I was suffering with all these UTIs to learn about how ozone could be beneficial. There's other benefits of ozone here, as you can see on this slide. I would recommend, if you're not familiar with ozone and want to become familiar with it, to join, go on to Simply O3, the website here, and download the guide. They have a really nice guide there that kind of introduces practitioners to what ozone is and how ozone can be used in a clinic setting or also at home. Patients can actually opt to get a machine and they can actually treat themselves at home, as I have. And I'm going to skip here and go to this next one. It's also really great for if there's a dysbiosis and leaky gut. This very, very beneficial. Rectal insufflations, vaginal insufflations are very beneficial. It has a very systemic effect as well. And of course, bladder installations. Like I said, I did the ozonated water for some time period and then graduated to the gas. The gas can be irritating to the bladder initially, so it's beneficial to start with the ozonated water first and then graduate to the gas, because gas has a more of a drying effect and it can irritate the mucosa. So I've often advised clinicians, if they're going to treat somebody with IC, to start with the water at a pretty high concentration of ozone, because the water provides a bit of a barrier and it seems to be more soothing to the patients. So I'll skip that and go over here. And the other thing is, I mean, they've been using ozone, dentists have been using ozone for quite some time, and there is definitely a local tissue healing effect, often attributed to, often because of the antioxidants and enzymes that are released because of ozone, but it can also increase the release of stem cells, nitric oxide production, and can help promote tissue reconstitution and repair. And it does increase oxygen transport to the tissue and can stimulate cytokines and interleukins in the immune cells. And finally, low dose ozone, scientific evidence has shown that the effect of it can, in a low dose, of course, indice a moderate oxidative use stress and activate antioxidant pathways. That's the primary mechanism of how this is actually doing this. So it actually induces a very mild oxidative stress, very, very mild, and that will activate the endogenous antioxidants. That's the mechanism of how it works. And then low concentrations, like I said earlier, can act on NRF2, which I've talked about before, which can then help with, the glutathione enzymes, HMOX1 and 2, and then NQO1. And they can also enhance the activities of superoxide dismutase and catalase. And it will also induce these ARE genes that are also important for who expression is regulated by NRF2 transcription. And these are involved in a lot of different functions, such as detoxification, DNA repair, autophagy, inflammation, lipid metabolism, and carbohydrate and amino acid metabolism. So this study that I just down here, it says the role of NRF2 in the antioxidant cellular response to medical ozone exposure. If you're interested in ozone therapy and how it can benefit your patients, I would download that study. It talks about all these different ways that ozone can mediate, different ways that NRF2 is mediated by ozone. So, oxidative, proteosis, mitochondria, inflammation, and cancer. So I would download that and read that. It's very, very fascinating. And I think it can really help the patients that, you're struggling with. So finally, you might want to know what I did and how I used ozone for my own health when I was struggling with interstitial cystitis. It's very tricky with patients with IC because they're constantly in a flare. So you can't just go in and give them a high concentration of ozone right off the bat. They probably won't come back to your office. So you have to go really slow, very slow. With IC, slow is the way to go. And so I would start with just rectal insufflation. That's it. Very low dose, very low concentration, 20, 30 gamma. Just start, see how they can tolerate it. And then you can gradually build up from there. I would say if you're going to do an instillation, ozonated water, like I said earlier, is very beneficial and less irritating to the bladder. They can drink a little bit of ozonated water. There may be some systemic benefits there. And the last thing they should be doing is the gas, because like I said, the gas is it can be very irritating to the mucosa. The other thing that is also available now with Simply O3 is they sell this vaginal kit. So they can actually do vaginal insufflations now. And that seems to have a very deep systemic benefit, more so than rectal insufflation. And then Dr. Schallenberger actually does have a bladder protocol. So if you're interested in grabbing that, you can get that from his book. And he does have a cocktail of lidocaine and other medications that can be also utilized if treating patients with ozone. And if they're having a lot of pain, it can help with mitigating some of the pain. So that's, in a nutshell, the ozone therapy. And this is where I can be found. So if you have any questions, feel free to reach out to me. My email is down here at the bottom. I'd be glad to answer any of your questions.